Okay, so the way that I impress upon monitoring is basically how do we keep the patient safe? Because, anesthetics are deemed safe, but in overdose, in any one of the anesthetics, we could reach an unsafe level. Sometimes patients are too deep under anesthesia and they survive anesthesia. But we could also do physiologic harm by having low blood pressure, low heart rate, high CO2, also affects perfusion to the kidneys. So, there's keeping the patient alive, but there's also doing it as safe and with as minimal effects as possible so that we don't have problems down the road. And that's interpreting all the data. Now, obviously, what I told you guys day one is I said it's extremely rare that you have a patient that's 100% normal 1 minute and then they spontaneously go into cardiac arrest. And a lot of times parameters start changing. And it's all about following the clues. I call them following the breadcrumbs. They're going to leave you little clues that something is not right. And it's recognizing first you have to know what is normal. What do we expect? What is considered dangerous or abnormal? And then how do we fix it? To me, I like to quiz students that are in front of me, and I've been helping in surgery. And I'm like, do you like that SpO2 reading? And if they say yes or no, and I said, why? Or how are you going to fix it? And then, I think they just expected me to say, is that normal? But you have to also understand, how do we troubleshoot it? Meaning, how can we fix it? Is it fixable? Is it a machine problem? Or is it truly a patient problem? So that's all, anesthesia is working the problem. It's assessing the situation. So first of all, is your vital signs, is the body's homeostatic response to anesthesia? Is the body responding? And you have to look at your heart rate and your rhythm, respiration and how deep they're breathing, our color, refill time, good pulses, look at your blood pressure, temperature. When we take all that data, this just tells us homeostatically, because remember, homeostasis is the body in balance. Are all body systems working together? Or is anything out of whack where it's going to affect homeostasis? And this tells us, are they acting normal? Now, reflexes are hugely important because anesthesia depresses the CNS, the central nervous system, and reflexes are an assessment of neurologic function. So a body's response to a reflex tells me, is it what I expect? Or is it not what I expect? And how do we, fix this? So what do we have to look at? Well, palpebral, which is tapping at the canthus. Now, corneal is actually when you put eye drops in the eye, or you can take a moistened Q-tip and actually touch the surface of the cornea. Now, like in a horse, that's a really good assessment. A horse that's light under anesthesia, say they're not deep enough, if something touches the cornea, a lot of times they will retract the eyeball. Sometimes they'll blink too, but what you're looking at is the eyeball will actually retract. Now, if an animal can sense, now think about this logically. A lot of anesthesia is logic. And I know you haven't done it yet, but some things just make sense. If an animal can touch or react to something touching his eyeball, is the animal ready to have surgery?
No.
If an animal can sense it's something touching the eye and react, then, and a lot of anesthesia is, first of all, is the doctor ready to start surgery? Because, you'll do anesthesia, you come in the OR, we have to do the sterile prep, we have to get up the ECG hooked up, the doctor's scrubbing. But the first thing the doctor's going to do when they come in that surgery or dental or whatever is they're like, is the animal ready? And they're going to look at you. And you have to have all this interpreted to say, yes, you can go ahead and cut. And you don't want to say, I don't know. That's not going to go over well because it's your job to know. I mean, you're going to find out shortly. They put a blade to that dog jumps off the table. They're probably not going to be very happy. So now swallowing and laryngeal reflexes, again, those are protective reflexes. Now, to intubate an animal, to put a tube over the epiglottis into the trachea, an animal cannot be swallowing because a protective reflex does not allow something to go into the trachea. So how do I know my animal's ready to be intubated? They lose their swallow reflex. They lose their laryngeal reflex, which allows the endotracheal tube. Now, I will have some animals that I go to put the tube in and they may try to swallow like one time, or they sometimes they give a little cough, and they were just a hair light, but I'm able to get the tube in. So, there's varying levels of being ready to intubate, but that's, you assess reflexes. And then this, what a reflex does, it tells me how deep is my animal, what level of anesthesia depth, and I'm going to talk about the levels of anesthesia, and that's what's going to tell me where they're at. Now, there are, when I just showed you that chart, that second chart I showed you, there are predictable things that happen to the animal in the levels of anesthesia. So, like level 1 is, or stage 1 is they're awake. I know what an awake animal should be doing. They should have good heart rate. They should have good, blink. They should be swallowing. If I pinch their toe, they should withdraw their paw. I mean, that's what I'm trying to say is, like, at stage 1, they are predictable. Now, as they move into stage 2 and stage 3, there are predictable things that should happen. Stage 3 is going to be when I intubate. Well, they should not be swallowing, or they shouldn't be blinking as much, or you might pinch their toe and they just kind of pull it back a little instead of going like that, because they're getting deeper under the anesthetic. So there are predictable things that you will need to know for this test. If I say this patient is doing this, this, and this, what level of anesthesia are they at? You should be able to tell me. So we're going to talk about that. And I will tell you, everything I teach you about this is the average everyday patient does this. You will have animals that fall out of the realm of normal. Sometimes I give drugs to a patient to sedate. You guys will find this in radiology. You pick a dose, you give it. Now, one dog might be like just slightly sedated, and they're kind of still looking at you and they're wiggly. And then the dog tomorrow might be like flat on its butt, not moving, like really deep. And you may use the same dosage. So you're always going to have animals that respond differently. But for the most part, what I have to teach you is what's expected to happen. And then, what do we do when we do have an animal that falls out of that realm of normal? And typically, I will say for monitoring, you will practice monitoring and using an anesthesia record in surgical nursing. But generally, we monitor every 5 minutes. We should monitor all the vitals, the reflexes, because things can change. You can get very different values from, in a 5-minute time span, sometimes a 1 to 2 minute time span. So you definitely want to be on top of it. So this is kind of the nuts and bolts of what we're talking about. There are stages and planes. There are 4 stages of anesthesia. Stage 1, stage 2, stage 3, stage 4. When you get into stage 3, there are 4 planes. So there will be stage 3, plane 1, stage 3, plane 2, stage 3, plane 3, stage 3, plane 4. So within stage 3, there are levels, and then stage 4 is basically we're almost getting ready to check out. So, remember when I showed you in that intro PowerPoint, I said there's stage 1 and stage 4 down here. This is awake, and below here is dead. And we hover when we do levels of anesthesia, we hover somewhere in the middle. That's where so I'm going to talk about where is ideal for your patient to be during anesthesia. Now, as you go from stage 1, which is awake, through stage 4, there's going to be a decrease, well, obviously in pain. And how do I determine that? Well, if you pinch their toe when they're awake, I mean, pinch your dog's toe and let me see what happens. Your poor dogs, I'm sorry. But as they're under anesthesia, and you guys should test this on your radiology patients next week, is when they're sedated, as they get deeper and you pinch their toe, you're probably not going to get as much of a reaction as they were awake, because now they're sedated. They have pain on board, or pain control, and they have sedation on board. So it's all a change from their pain perception, motor coordination. Obviously, they shouldn't be moving. Their reflex, their general muscle tone. When you feel an animal that's awake and they have tone, as they get sedated, they just feel like, a bump on a log, or, you drop their leg and, they don't have a lot of tone. When they start to wake up, all of a sudden they get muscle tone back because they're becoming more conscious. And then obviously cardiopulmonary functions, probably the most important, is the anesthesia altering cardiorespiratory function? It is going to be, I tell everybody, your animal's heart rate is going to be lower than when it was awake, and they're not going to be breathing as often. I expect that under anesthesia, but is it to a point it's detrimental for the patient? That's the goal. Are we getting to a point where it's too much? And then we got things to talk about. So let's talk about stage 1, and you should take some notes or what I mean by this, but this is stage 1 is when they're completely awake with nothing on board, all the way to sedation with pre-meds. So stage 1 really can vary. Now, when you guys, for example, when you're in radiology and you give sedation, your patients are going to be in stage 1. Sedation does not get us past stage 1. That's very important to understand. Stage 1 can be light sedation, it can be medium or deep sedation. Now, your goal in radiology is you guys want to be in deep sedation because you're going to be taking a bunch of x-rays. So the protocol that you guys use, the Dexdome Tord, is a potent sedation protocol. You expect a loss of muscle tone. What we tend to see in this stage, and this is what I want you to be able to also explain. What do you see? Well, they can be fearful. They can be disorientated. Sometimes you can get struggling. Urination and defecation can sometimes happen because, as they're getting sedated, sometimes they can kind of lose their bowels. If anybody, if your clinic uses hydromorphone as a pre-med, a lot of times you give the pre-meds, and a lot of times by the time they come out for their catheter or you're getting ready for something, sometimes we'll go like, do you smell something? And you lift up their tail and there's a nice little present. Now, hydro stimulates the GI, causes GI stimulation. So sometimes, they defecate. Sometimes you'll get a little increase in their heart rate and respiratory rate because they feel funny. They might be stressed. They might not understand what's going on. But also, if they're deep, that could also go down. So it doesn't always, start out high or stay high. It can start to go low. But what we tend to see in stage 1 is they tend to they're not usually able to stand and maintain their recumbency, which is, sometimes they lay down, sometimes they sit. Although I will tell you, you guys, I think, will give the drugs IV, and they'll kind of pass through sedation pretty quickly and get pretty deep. If you give like a sedation IM, sometimes those dogs are much slower, but they're able to walk to the prep room or they're able to walk to the radiology room. So sometimes when you give it IM, sometimes the patient, they can still lift their head, wag their tail. I would say this stage is very, it's drug dependent and dose dependent, patient dependent to some degree, but It's a little different. Now, stage 2, I want you to know it's called the excitement phase. Now, what you guys are doing in radiology, you're just sedating. But say you were in surgery rotation. So in surgery rotation, we usually give them their pre-meds in the muscle, and then we put them in a recovery room and we let them fall, get sleepy. Sometimes we have to carry them into the prep room. Sometimes they walk into the prep room, and then we place their catheter. And then once their catheter's in, now we're ready to go under general anesthesia and give the propofol. So propofol is not a sedative. Propofol is what's called an induction agent. And propofol is a drug that gets you from sedation to general anesthesia. It's like a bridge, okay? Because you cannot intubate an animal on dexdomitor and butorphanol. You should not be able to. If you were able to on just those two drugs, that drug, that's like kind of overdose level or probably like an adverse effect. If you guys remember when I was talking to you about how do I know my patient's okay on, this is very important, so please listen to me. How do I know my patient's okay on dexdomitor? Because it's extremely potent. When I gave it to this dog that one night, I gave it and we were starting to take x-rays, and I'm like, his heart rate was getting down to the 32/28, which is really, really, now their heart rate goes down with dexdomitor. That's normal, but that was really low. And then the dog had no blink, and his jaw tone was completely flaccid, like flapping in the wind. Normally they have a little bit of jaw tone, even sedated. I could pull out his tongue and I could have put an endotracheal tube in. That's way too deep on those drugs. So first of all, I was worried about his heart rate. I didn't like his color. His respiration was like 4 breaths a minute. Everything was telling me, I'm like, this dog is deep, deep. And when I could open his mouth and pull out his tongue, I told the doctor, I was like, this dog is way deep. We got to reverse him. And she was like, well, we only need like a few more x-rays. And I'm like, you want x-rays of this dog or a dead dog? I mean, and I had a good relationship with her, but I was, I was like, I'm very comfortable with this drug. You know me. I'm extremely uncomfortable right now. This is way too deep. So that just gives you an idea, is like, how do I know? How are you guys going to know in radiology? Is your dog okay? Well, you should have a little, and I put all that on that sheet. You should have a little bit of a blink. You should have a little bit of jaw tone. They might respond to their name. You could even sometimes get a tail wag. They should have some, if you pinch their toe, they should react a little bit. It should be slow. So that's how you know. But I'm telling you also, how do I know it's too much? Now, when you take an animal from sedation to general anesthesia, they're going to pass through stage 2. Now, stage 2, how do I know a patient is in stage 2? Well, let me give you an example. If you do a really good anesthesia, you never even see stage 2. If I have a dog that's sleepy on the pre-meds and the student gives the propofol properly, they will go right from stage 1 to stage 3. Now, they pass through stage 2. This stage should only last about 30 seconds to a minute or two. I mean, you don't want them in stage 2 because this is paddling, vocalizing, struggling. It's kind of like they don't know where they're at. Is stage 2 where you'd want to be for people? No. So Megan, if your dog was if you had a dog that was painful and you needed hip rads, you should be able to do it with just sedation and be in stage 1, but you probably have to do a more potent sedative. If the dog was reacting with the sedative during the radiographs, you could give propofol and you could knock them out completely, but that would be in stage 3. Stage 2, we never want to be in stage 2 for anything. We always want to get out of stage 2, if that makes sense. So stage 2 is kind of like, think about, and whether you're religious or not, people talk about heaven and hell and there's purgatory. Stage 2 is like purgatory, except you're either going to go to heaven or hell. You're not going to hang out in purgatory. But think of it, it's like a mid-stage. It's kind of like in between. So the problem is, when I tend to see stage 2, sometimes when people are learning to give propofol for the first time, they give it too slow or not enough. And if you give propofol too slow, you won't get through stage 2. And all of a sudden the patient like throws their head and they start looking around and sniffing real weird, and they start crying because they kind of don't know where they're at. They're like in a mid-consciousness level. So it feels very weird for them. And some patients are going to act out. And what I do is I tell students, just push it a little bit faster. You're probably just giving it too, now you can't blast it in. There's a way to give propofol. You know, there's too fast, too slow, just right. If you give it too fast, they can stop breathing. If you give it too slow, they can go through excitement phase. So you kind of got to give it at a consistent, steady 30, second kind of administration. You tend to have dilated pupils, a lot of muscle tone because they're fighting. They can have, blinking, sometimes chewing. This is the key. Their actions at this phase are not conscious. When they are in this stage, you definitely, I've gotten a head to the chin, almost bit my tongue. That felt real good. I was like an uppercut. Because if you're holding them and you're not paying attention, if they rear their head, I've had people get bit and they don't let go in this stage. You have to, whoever is controlling the dog really has to be paying attention, because if they do something, they're kind of, and have a hold of the dog. These animals can throw themselves off the table. You can go from I look sleepy to I'm crazy. So just be really cautious. As you're coming out of stage 2, you're going to feel the animal relax. If you're holding them, you just feel them get heavier. You'll get this muscle relaxation that kicks in. Respiratory rate. A lot of times when I give propofol, and I tell the students this, when you give propofol and you're just about ready to intubate and go into stage 3, they'll take a deep breath, like, and I'm like, okay, it's kicking in. It's like almost a predictable thing that most patients will do. And then their blink should be diminished. And that tells you that you've gone through. So I feel like I've said a bazillion things. The main thing is that you don't want to be in stage 2 for anything. It's a transient phase. We're going from stage 1 to stage 3. A good induction passes right through, and it's called excitement phase. And this is the stage they should pass through, from sedation to general anesthesia. And again, if you were masking a patient, I will tell you, when you mask patients, and I'm not a fan of mask induction at all, when you mask them, you're going to see stage 2, because it takes them longer to go from that sedation to a sleep with gas anesthesia. Propofol is a quick induction agent. Alfaxin, quick induction agent. Ketval even is a decently quick induction agent. Those drugs are all induction drugs, and they're designed to get you from stage 1 to stage 3. But when you box a cat down, when you mask an animal down with an anesthetic, it takes longer for them to get the effect of the inhalant. You're going to see more of stage 2. And that's another reason why I'm not a fan of mask induction. I don't like boxing cats down, because the excitement phase, it's very stressful for the patient. So now, this is a very important stage. Stage 3 is when we're approaching surgical anesthesia. So we're getting to where we need to be. But remember, there's 4 planes. So stage 3, plane 1, is not adequate for surgery. This is called light anesthesia. So if my patient is stage 3, plane 1, they're considered light. But the big thing is here, they are not ready for surgery. This is right after you give the propofol, right after you intubate, and this is most likely that first 10 to 15 minutes while you're in the prep room, like you're hooking up the machine, you're flipping them over, you're getting ready to clip them for surgery. Like, they're asleep, but they're not ready to be cut yet. They still have to get a little bit deeper. So what you start to see is the respiratory rate goes from irregular, and they start to get into a regular respiratory pattern. Their eyeballs. I am a huge, huge person on eyeball position. I'm like psycho if I can't see the eyeballs. Like, it's a very good predictor of where my patient is. Now, everyone listen to me. When they're awake, they're looking at you, right? When an animal starts to get under stage 3, plane 1, the eyes are going to start to rotate ventromedial like they're looking at their nose. That's where I want their eyes under anesthesia. Now, if an animal continues to get too deep, the eyes are going to rotate back up. So if I have an animal under anesthesia that's looking at me, central, it means two things. Either they're about to wake up or they're about to get really, really deep, potentially too deep. So when you have an animal looking at you, you have to determine, am I about to jump off the table or am I about to check out? It means two things. So eye position is a very predictable predictor. Makes sense.
Daros, how do you determine that if the eyeballs are looking at you while they're under anesthesia?
So
Like,
all
how do
you
you determine?
so when they're on the table, it's a good question, like sometimes they're on their back. I just kind of lift up their head and just pull like their eye open. And what you'll see sometimes when their eyes are in a good spot, if you do that, you see just the whites of the eye because the pupil is rotated ventral. And sometimes you'll just see like the very top of the pupil because their eye is down. So I just kind of like look under their head and kind of like pull their eyelid open just to see if that makes sense.
Okay, thank you.
Yeah, you should, if you've ever watched them in surgery, usually the head is out from under the drape. So you can like touch the head. You can, I mean, even though the drapes are there, I can kind of reach under. So say you have a little patient, like a little chihuahua, and the whole thing is covered with drapes. As long as you're not by the surgical site, you can kind of lift the drape up underneath. Sometimes I've even used, I mean, I don't like phones in surgery, but and a lot of people use their flashlight and they'll kind of like use their flashlight and kind of look at, because it's dark. In surgery at Purdue, we had flashlights in all our ORs, so I would keep a flashlight under there so I could like look at their color, their eye position, if that makes sense. Yeah, so you should, it's only hard if they're doing a procedure like on the face or the head, then sometimes, but I've sometimes had my doctor, if they're like working near the eyes, I'm like, hey, what's their eye position look like? If they're like right there, that's the only time it's really difficult. And that drives me nuts because I really like to be able to look at their eye. I like to be able to test their palpebral because things that you should start to see. So I talked about eye rotation. Their pupils will be a little bit constricted. Sometimes that's different with different drugs. This is where we pass the endotracheal tube. So that's another thing to know. When you guys give the propofol in the prep room, an animal in stage 3, plane 1 will allow intubation. You can't intubate in stage 1 and you cannot intubate in stage 2. The first stage you can intubate is stage 3, plane 1. That kind of sounds important. And this is where you would hook up the gas. Now let me explain something. So since some of you have never done anesthesia or maybe even seen anesthesia, you have a pre-med. I put a catheter and I give the propofol. The propofol is an induction agent, and that's what gets you to stage 3, plane 1. Then you put in an endotracheal tube and you hook up the machine, and the machine is going to deliver oxygen and like isoflurane. Now, the isoflurane is what's called your maintenance agent. The maintenance agent is what keeps them asleep. And there's a dial, and when we get into gas anesthesia, when I talk about inhalants, I talk about what level to put them at, where to start, how to adjust, because your propofol only lasts about 10 minutes. That injection that you gave in the prep room is going to be out of that animal's system in 10 minutes. So the only thing that animal has on board is its pre-meds and the inhalant. So the propofol, because sometimes I have animals not doing well under anesthesia, and it's 30, 40 minutes, especially on an essay question. The student will say, oh, it's the propofol. I'm like, if we're 40 minutes into the procedure, the propofol's gone. Like, it's no longer a factor. Now you have, like, what do I have on board? My pre-meds hang around, and then I have my inhalant. So gives you an idea. One thing also is animals in stage 3 plane 1 will still have a blink, but it should be diminished. They should have some jaw tone, but it is diminished. They should not have a swallow because you just intubated them. So I don't expect a swallow reflex, but a little bit of blink, a little bit of jaw tone, a little bit of withdraw. So if I pinch their toe, they're probably going to still feel it, but it shouldn't be like I completely yank my leg. It might just be like you pinch my toe. I do that a lot too. When I have an animal laying there asleep and, you know, their front paws are by me where I'm doing anesthesia, is I'll just take my fingers and I pinch either their toe or I pinch their toe whip. And I pinch hard because I need to know if they react to me. I don't want Dr. Paul coming in and starting surgery, because if they can feel me pinching a toe, then they're obviously going to feel him when he goes to like put the blade on them. Now, stage 3 plane 2, now we're on the ISO. The dog is inhaling isoflurane and the dog is getting deeper. This is surgical anesthesia. This is where I want you to know, this is where you want your animal for surgery. So stage 3 plane 2 is surgical anesthesia. Remember, stage 3 plane 1 is light anesthesia. Stage 3 plane 2 is adequate. Typically, you'll start to see your heart rate and respiration. They were starting to go down, they level. So they kind of become a regular heart rate and respiration. Your heart rate should be lower than when it was in the prep room. Blood pressure might be a little bit lower, but what I want here is relaxed muscle tone. The patient feels relaxed. You don't want to see any swallowing. Now, an interesting thing, looking for a swallow reflex, when you pull the tongue out and you go to intubate, that's normally when you assess the swallow reflex. Normally when they're asleep with a tube in, I'm not like sticking my fingers back in the throat to see if they're swallowing. What you can do is when they're laying there is you can watch their throat area. There's been times out of the corner of my eye, like I was looking at the surgeon or I was watching surgery, and all of a sudden out of the corner of my eye, I see their neck move. Because if they swallow, you see this pull. So if I start to see, that's sometimes the first place I see swallow come back, is you just see in their throat, you can see that they swallowed, which you don't want them doing during surgery. If they could swallow, that's a reflex coming back. That means they're getting light again. Now, if you're waking them up, that's great. But if they're in the middle of surgery, you don't want to swallow. We want ventromedial eye rotation. Now, let me say one thing real quick, because I'm going to finish up because I know we're about at the end. Animals will get predictable every time you do anesthesias. The more you get experience sedating and then you go through anesthesia, you know what a patient should feel like. I had a case where a dog, it was a teaching lab at Purdue. I had vet students, and all they had to do was anesthetize the dog, keep it asleep for 30 minutes, and wake it up. They were learning how to do anesthesia. And right after the guys, they gave the induction agent. So they pre-medded with ACE and butorphanol. Pentothal was our induction. They were going to intubate on halothane. And as soon as the student intubates, and there's a lot going on, he was trying to get the fluids, one was trying to hook up the monitor. I always go to reach over and feel the jaw tone. It's just a habit. As soon as I felt this dog's jaw tone, it was completely loose. And I looked and he had central eye position, was pale, and his heart rate was only 30 beats a minute. Now, he did not have dextometer. And I was like, whoa, this dog is way too deep just after induction. Like, dogs don't feel like they should have some jaw tone. eyes should not be central. They shouldn't be pale. We turned them off. I started bolusing fluids, and I got the anesthesiologist over, and I went and got atropine. We woke the dog up immediately, and when he woke up, he blew out this awful diarrhea, and it was just like, peed himself. And found out later, like, that dog had been having vomiting and diarrhea for days. He was one of our lab dogs, but he obviously maybe was sicker than our other dogs, and he had just an adverse effect to the anesthesia. Maybe maybe because he was sick, he was a little dehydrated and had this diarrhea. But how did I find now? Had I left that dog on, he would have died under anesthesia. I have no doubt he was getting ready to check out. All my vitals, but you see what I checked right after induction? I'm like, you have no jaw tone, your eyes are already central, you're pale, you don't feel good pulses. Everything was pointing to what is going on. So, and because I know what a dog's jaw should feel like after anesthesia, that was the first thing that triggered me, was his jaw was just like super loose. I'm like, whoa, you should have some jaw tone. And that triggered me to look at other values that pointed me into adverse effect. And that's a very rare case. But then we found out with him being sick, he probably just, the pre-meds and everything was just too much for him because he was not feeling good. So anywho, I want to stop here because I want to talk more about stage 3 plane 2. Do you have any questions?